Hi, well, thank you very much for being here today. After hearing all of that about pressure ulcers, what I'm going to talk to you today is about our journey in Southampton, and it's a journey that has been quite a long, drawn-out process. However, we're really seeing some benefits of all of our hard work. So what I'm going to present on is a new risk assessment tool that we have developed over the last 2 years. Now, the background to this, we're a very large acute trust. We've got about 1,400 beds. We have regional trauma centre, so we have helicopters arriving 7 or 8 times a morning and an afternoon with lots of different cases with polytraumas. We have a regional centre for neurosciences, for cardiac, for oncology. We've got our new plastics team that are now related to our major trauma team. So we are having the most unwell patients admitted to our hospital. But we're striving and continuously striving to move forward to reduce pressure damage, but we're still finding that it's happening. So when we have a pressure ulcer occur within the trust, within our care, we don't use the 72-hour rule. So any patient that's admitted to our care, if they develop a pressure ulcer, then we class that as happening within our care. We go forward and we scope that patient with the ward manager, the matron, and a member of the tissue viability team within 72 hours of the damage being validated. And what we do at that point is we look at their notes, we look at everything that's happened to that patient, and we first of all try to establish what the root causes are. And the reason for that is that we can put the actions into place straight away to make sure we're making a change and we're moving things forward. The ward, if we feel that the pressure ulcer is avoidable, I know we're looking at getting rid of the avoidable and unavoidable, we still use them at the moment, and for us the avoidable means that we've missed something along the way, so we haven't put everything in place that we could have done. So we do a root cause analysis, and then the cases are then discussed at panel, and we're very lucky in our area. We have a panel with our patient safety team, the wards come and present, and we also have commissioners on our team as well. So they come to the panel and they actually look at the information straight from the ward manager's mouth. So we were having these panels happening. We were having quite a lot of pressure ulcers develop within our care. And what we were finding was that there were several themes, but the most important of those themes is that we had an underestimation of the level of risk. And because we were underestimating the level of risk, as Jackie said earlier, a risk assessment doesn't prevent pressure damage, but what you do with that risk is what prevents the pressure damage. So the fact we were underestimating the risk was meaning that we weren't putting any interventions into place within the trust, and so the pressure damage was occurring. So we were using the Braden tool at that time, and for us, it wasn't working. What we were finding was that our staff were actually making up scores. We had an equipment system that if they needed pressure relieving mattresses, they had to put in a score to say why they needed it. So because the patients hadn't scored as a high risk, they were making up the scores and just putting any old scores in just to get equipment. The interventions weren't always assessed, so some nurses that knew about pressure ulcers or had attended the teaching did put interventions in place, but in a lot of areas, because they were coming out as just at risk, nothing was happening. We were also relying a lot on the staff's clinical judgment. And the way that the NHS is moving, and I'm sure it's the same in many trusts, we have a very junior workforce, we have a very depleted workforce, and so quite often when we're expecting staff that are extremely busy in completing risk assessments to use their clinical judgment at the same time, often that's overlooked and we're not always getting to that point. Because of that, we are having no care plan put into place for any of these patients. So these patients we knew were having a problem because initially they weren't being assessed as at risk. So what we did is we looked at the many different tools that there were available, and we took a lot of these tools to a focus group. So we had a big focus group meeting, which was very well attended by a lot of our matrons, and there were a couple of our divisional heads of nursing. We looked at the different tools, especially Purpose T. So we were hoping to implement Purpose T. At this time, so this was back in 2015, there were no care plans with the Purpose T tool at that time. And our focus group found that Purpose T was too complicated. They felt that it wouldn't get completed in our area. So we were looking then at finding something that would meet our requirements. And what this group came up with, that it had to be quick and easy, it had to incorporate learning from other cases, so we needed to make sure that issues that hadn't been picked up in other cases were in this form, so that we didn't have these cases and things happening again. We needed to concentrate efforts for patients that were really at risk, and those ones that weren't at risk needed to be screened out quite quickly and simply, so that the interventions could be put into place for the patients that really needed it. And we needed to reduce the amount of documentation to an absolute minimum. I don't know if any of you have the same, but we have an admission booklet that the ward staff have to fill in when a patient is admitted to the trust, and it's probably about this thick. So when you look at that, if you go putting in something really complex, they're not going to complete it fully. They're just not going to do it. So what we wanted was to make sure that we were getting the staff doing it straight from the beginning. So we decided to develop our own tool. We're using all of this as information. We use the latest national and international guidance that Lizette had referred to earlier. We decided to use colours rather than numerical scoring, and a lot of that was to do with the fact that we RAG rate everything. In hospitals, we have RAG ratings. It's either red, orange, or green for everything. So we decided that would be a good way to go forward. And also, we wanted to know what we could call it. So we wanted something catchy, and I can't take credit for it. It was not me. It was a member of my team, Ellie Norden, who I thank. She came up with the name, and we came up with the Pressure Risk Evaluation and Skin Screening Tool, which we call PRESS. And we launched this with a campaign, and the campaign is React to Red and then Press to Assess. So it worked quite well for us. It was quite catchy, and we were moving forward with the Press tool. So this is an example of the tool. It's very, very quick, very simple. You go along the top and you screen out the patients that score green. So if your patients are able to move, they have normal skin, and they haven't got any history of any comorbidities, then you can score them out quite quickly, and they will become a green patient. If you then go on, that's the screening tool. If you go on then to the risk assessment, so this is for a patient that has scored anything in the screening process, you will then go through each of the questions that there are. So we look at skin, previous damage, moisture status, movement, I can't read it either. I think all of us have got problems with our eyes. Diabetes, sensory perception, vascular history, and nutrition. So we try to incorporate all of these different aspects. You go through and you tick either in the orange or the red. If you come out with only orange ticks, you would go forward as orange. If you come out with any red ticks, you are a red case. So you would then move forward. We couldn't use amber, which we wanted to use because of the new palliative care pathway. It's called the amber pathway in some areas. So we were asked not to use amber. So that was one of the learning curves that we found very quickly with the tool. These are then the care plans. So we then have a care plan that you go to when you've done your risk assessment. And this basically will go through everything that you need to put into place for your patient for that level of risk. So it takes away any worry if your staff hasn't got the right training, if it's an agency staff member that we all rely on a lot within the acute sectors, then they know exactly what is expected and what they need to do. So when we developed the tool, we did lots of focus groups. We then decided to do a small pilot. So we used 2 wards, both of which had several, I have to say, grade 3 and 4 pressure ulcers develop in both their areas. So they were very willing to try this new tool. So we had 2 wards. We went in, we audited all the patients as a tissue viability team. So we went round, we looked at each patient on that ward. There were the same members of staff. They did a Braden assessment on the patient, and then they also did a press assessment on the patient, so that we knew what the patient score should be and what the ward was actually scoring them at that time. We then implemented the tool, and we went back again after we'd implemented the tool and had a look at what the risk level for those patients was. So this was the pre-pilot scores, and as you can see from the first chart, there were on the first ward, which was the respiratory ward, there were 25 patients, I think that says, that were scored at low risk, when actually 21 of those should have been high risk. So we can see straight away that Braden for us wasn't working. It was underestimating the level of risk for those patients. And then they really struggling to find the right risk level for all of their patients. Then post-pilot on that ward, as you can see, they actually had pretty good risk assessments using the press. So using the press assessment, they were able to show that there were 13 patients they'd assessed as high risk, and there should have only been 14. The one patient that was the discrepancy was actually a patient that had been assessed as low risk as green, but actually he had diabetes. And what we've decided to do in our trust, due to a root cause analysis case, is put everybody with diabetes as high risk. So they always are an orange or a red, because we had a particular case of a young 20-year-old guy who came into hospital for an operation on his wrist, who sat in bed watching movies on his laptop with his heels dug in with the laptop on his lap, and after 3 days complained of a sore heel, totally mobile, totally okay, and got a grade 3 pressure ulcer on his heel. So that's another one of our learnings that we've incorporated. So all of our diabetic patients are then classed as at risk. The second ward, we had exactly the same. Pre the implementation of press, we had 18 patients that were deemed at low risk, and actually 20 patients should have been at high risk. So, and they only had one, I think, that was actually risked at high risk on the Braden tool. Following the press implementation, we had perfect scoring. So of the patients that were high risk, 20 were assessed as high risk who should have been high risk. Patients that were on turnaround, now we call it turnaround, which is a skin bundle. So the S-skin we have turned into a form, and our director of nursing has named it turnaround. So we call it turnaround, but what it is, it's 2 hourly interventions, repositioning, giving them a drink, making sure that their area is not cluttered, toileting, etc. It's all called turnarounds. So pre the audit, the patients that were being put on turnaround were very low. Post the audit, you can see that actually all patients that should have been on that process were actually put on that process. And it was the same with patients that had existing pressure damage. This was one of the big failings of the Braden tool, was that there's nothing in the Braden tool to look at previous pressure damage or existing pressure damage. That isn't taken into account. So pre the implementation of press, we didn't have, as you could see here, all of our patients on a good repositioning process, even if they had existing pressure damage, because they'd been underestimated with their risk. But post, when we went back, we had 100%. So every patient was on the right interventions. The next thing we looked at was feedback from the staff, and usually, I'm sure if any of you have implemented anything new into your organisation, staff are extremely good at giving you lots of feedback. Especially, I was expecting an awful lot of negative feedback because I'd introduced care plans. So not only had they just used to fill out a Braden, but now they were filling out an assessment, and I was asking them to fill out a care plan daily. So I was ready and waiting for an influx of really negative feedback. But actually, the staff feel it's logical, easy to complete. They were really happy about the screening element. Care plans they love because they don't have to think about things. They can just tick and say they've done it. They felt it was more accurate and it was concise and clear. We had really clear documentation on the pathway of the patient from admission through the door. We have a time written down to make sure we know how quickly this is being done. We have a prompt for the use of the right equipment. Turnaround was in place straight away, and the education was really quick. We'd put in this big program of education to roll this out, and the wards, after 2 mornings attending the handover, said, "You don't need to come back. We're happy. We know how to do it. You don't need to keep coming back and telling us." So the education was really quick. So following the results of the pilot, we made a decision to roll out across the whole trust. And I have to be honest, I had quite a few sleepless nights thinking that we were going off NICE guidelines because it wasn't a recognised tool. But we had to take a chance and we were going to go forward with this. So we implemented it. We literally were sent away after the education. We went round and did a couple of sessions on each ward, and that was enough. The Trust invested in coloured printouts of the care plans, which was great, and they've actually put the assessment within the document, the admission document, so that's all printed in colour. And the staff feedback continued from across the Trust to be positive, and still, so far, no negative. We've still got really positive from all staff members. So we did an audit 3 months post rollout. The first question that we looked at was the risk assessed using the tool an accurate reflection of the patient's level of risk? And again, what we did is we looked at what the score was on the admission document, and then the team did the same score. And what we found was 97% of patients actually had the correct level of risk assessed for them. Was it completed and documented on admission? So that's within our 6-hour rule. 97% again were completed within the 6 hours of admission. A care plan in place. At 3 months, we only had 84% compliance with this, so we still had quite a bit of a job to do. We weren't too worried about that because this was a new element, so we had to take that on board. We had good patients where turnaround was initiated for 96% of patients, and the appropriate pressure relieving was in place for 93% of patients. So we did really good. A year on, we did a larger audit, we added in more questions, but again, what we were finding is we were staying in the 97%. So even a year on, we've got 97% of our patients assessed as having the correct level of risk and within 6 hours of admission. And also, we checked on this audit after a year of whether it was being updated regularly. And again, we had 97% of all of it was being updated on a regular basis. Correct care plan in place, we went from 83% up to 94%. That's really good. We're still working on that one. And the care plan was commenced on admission in 98% of cases, which was brilliant. So we've really started to see a benefit. 99.5% of patients were on turnaround after a year, which is brilliant. We're really seeing that they're having the interventions, and they're having those interventions commenced on admission. So we've had really good success. We still don't have any negative feedback, and we've got a really high completion percentage for this tool. So how did we measure the success as well as that? Well, we looked at our pressure ulcer numbers, and I actually have, these are our true figures. I asked the Director of Nursing if I could use them, and she said, get out there and do it. This is what we have. So you can see grade 2 pressure ulcers. At the bottom are the totals, and the totals in the brackets were our target. So that was our 20% target for that year. So 2014-15, we had 193. 2015-16, it was 195, so that we'd gone up. That's why we introduced press. So 2015 is when we did the pilot, because we'd had an increase. So 2016-17, we went down to 140, and 2017-18, we've gone down to 104. So we are making a good reduction. Grade 3s and 4s, we've had a lot. We've got a massive trust, so we do have a lot of pressure ulcers within the trust. In 15-16, we had 32 avoidables. So these are ones that had gone through our panels and been deemed avoidables. We introduced in April 2016 press, and at the end of 2016-17, we only had 12. So we'd really made a massive, massive reduction in the grade 3s and 4s. 2017-18, we haven't done quite so well, but having said that, we are looking at correlations, and we have had one of the worst years in Southampton because of our level of people coming in. So our acuity is massive, and our turnover is 32% higher than it was last year. So our admission rate has been much, much more. So we're still working, we're still moving forward, but we have still seen a reduction. So now we're rolling out to our maternity and our pediatrics. Pediatrics use a different type of tool, but they actually love press, and we're going to roll it out in pediatrics, and we're starting to do risk assessments in maternity. We've got a new campaign, because one of the learnings now from our new RCAs has been that the patients that are actually developing pressure ulcers have been incorrectly looked at as what is independent. So if you can walk in and you can get in and out of bed, you're classed as independent, even though when you're in bed, you can't move. So we're going to do a new campaign to try and get staff to understand that. We're trialling press in other areas locally, so it's now going out to the community, and there are another 2 hospitals that have approached us and that we're more than happy to start sharing this tool with. And our aim continues to monitor, embed it in practice, and actually achieve our goal of 0 avoidable pressure ulcers. So thank you very much.